Thanks for this opportunity to present on such a global scale. This is my first time presenting on such a huge global scale like this. I'm working as a senior assistant in surgical gastroenterology at Caritas Hospital in South India. I had done the study during my post graduation a few years back. The study is about prevalence and the associated risk factors of Barrett's esophagus in patients undergoing esophagogastroduodenoscopy in a tertiary hospital. This is done at Amla Institute of Medical Sciences, Thrissur. Now, I'll give you a small overview of what Barrett's esophagus is. It is a condition in which an abnormal columnar epithelium that is both gastric and intestinal features. It is the clinical importance of this is that it is predisposed to malignancy. So this columnar epithelium replaces the stratified squamous epithelium, which normally lines the distal esophagus. This is named after an Australian surgeon named Norman Barrett, who saw this columnar epithelium lined esophagus in the year 1950. Now, this can occur as a consequence of chronic gastroesophageal reflux disease. This damage is because of the acidic contents from the stomach, which damage the esophageal squamous epithelium. This causes it to heal through a metaplastic process, forming columnar cells. And this columnar lined esophagus there might not be any symptoms, and it is a clinical importance because it is considered as a risk factor for adenocarcinoma. It is diagnosed on endoscopic examination, and there are two criteria which must be fulfilled. And the first criteria is that endoscopically the columnar epithelium must line about 1 centimeter or greater of the distal esophagus, and the biopsy specimen must show evidence of metaplasia, which is a change from the adult tissue to another. And this Barrett's is also categorized into two types based on the this extent of this change. Long segment that is above 3 centimeters above the gastroesophageal junction, and short segment which is less than 3 centimeters. A short segment is more common. This is an endoscopic view. You see that it begins with esophageal injury from the gastric contents due to the esophageal reflux, gastroesophageal reflux, and the patients with long segment Barrett's generally have a severe GERD. And there have been some physiological abnormalities which have been documented and which is causing this sort of a change in the epithelium. Some of them are extreme hypertension of the lower esophageal sphincter, which causes gastroesophageal reflux, and an ineffective esophageal motility. This causes defective clearance of the reflux material. There is also gastric acid hypersecretion, which causes highly acidic gastric juice to reflux into the esophagus and damage the cells. There is also duodenogastric reflux, esophageal injury that is caused by this, and decreased salivary secretion of EGF in the saliva. And this causes delayed healing of the reflux damaged esophageal mucosa, and decreased esophageal pain sensitivity of reflux caustic material. This causes failure to initiate therapy. Coming to the endoscopic surveillance, according to American Gastroenterological Association, the ASGE, the British Society of Gastroenterology, American College of Physicians, and the European Society of Gastroenteral Endoscopy, endoscopic screening for Barrett's is done only for those who have multiple risk factors for esophageal adenocarcinoma, like those who are aged 50 years or above, those who have a chronic gastroesophageal reflux disease, white race, male gender, central obesity, hiatus hernia, history of smoking, and a history of Barrett's or adenocarcinoma in the first degree relative. And coming to the treatment, most of the studies suggest that proton pump inhibitors can reduce the risk of malignant progression in a case of Barrett's. And the latest guideline by the ECG recommends that every Barrett patient should receive at least once daily dose of PPIs. This is said to reduce the chances of adenocarcinoma or chemoprevention. And there is also evidence to suggest that aspirin also helps in protect against esophageal adenocarcinoma by inhibiting the COX-2 and by a mechanism that is independent of COX-2 inhibition. This is said to even reduce the accumulation of somatic mutations, decrease angiogenesis, It also decreases proliferation in Barrett's metaplasia. So aspirin is given in a dose of 375 milligram daily to reduce the levels of prostaglandin E2 in Barrett mucosa. Coming to the therapies, we don't go to surgery initially. We first try to control or resect the area using endoscopy. The newer modalities of endoscopic therapy, like endoscopic ablative therapy, which uses heat, which can be delivered by electrocoagulation, laser, argon plasma coagulation, or radiofrequency energy, or even the cold temperature, that is cryotherapy or photochemical energy, photodynamic therapy can be used. And the other one is EMR and ESD, that is endoscopic resection, endoscopic mucosal resection, and endoscopic submucosal dissection, in which an endoscopic knife or a diathermy snare is used to remove the last segment of Barrett's mucosa with a submucosa, that is EMR and ESD. Coming to my study, my aim was to study the prevalence and associated risk factors of Barrett's esophagus in all patients undergoing OGD scopy, esophagogastroduodenoscopy, in Amala Institute of Medical Science. My objective was to assess the prevalence of Barrett's esophagus and find out the risk factors and their association with Barrett's esophagus. This was a cross-sectional study conducted in Amala Institute of Medical Sciences, Thrissur, and from December 2019 to January 2021. We included all patients undergoing OGD scopy for various indications, and patients above 30 years were considered who undergo diagnostic OGD scopy. We included all those patients undergoing OGD scopy, and information like age, sex, their residential area, their BMI, recurrent heartburn, features of regurgitation, smoking, and alcohol history were considered and recorded for all these patients. Now, we took biopsies from these patients, those who had features of doubtful intestinal metaplasia on OGD scopy, and biopsy specimen was sent for histopathological examination. Coming to the results, demographics. In the study, we had a minimum age of 11 years and a maximum age of 86 years. The mean was about 54.5. There's another table showing the same, the age-wise distribution. We had the highest number of age was people in the age 61 to 70 years. And males were about 59.3%. That's about 60% that is totally 230. We had about 388 patients. This is a chart showing the age, the sex-wise distribution. Body mass index was also considered a risk factor, so we included it. And in the range from 18.5 to 24.99, we had about 63%, that is about 244 people who had this body mass index. There's a chart for the same. Other associated risk factors like symptoms of gastroesophageal reflux, like heartburn, was also included. And this was present in about 50%. That was all in between. That is about those who had heartburn was 50%, and those who did not have was also very nearby. That is about 49.7%. And the frequency of regurgitation, it was quite low. It was 37% in our study. Those who had, that was about, the number comes to about 146. And smoking was also included. It was about 23%, 22.9%. 89 patients had a history of smoking, and about 300 patients did not have a history of smoking. And about 41.8% patients, that was about 162 patients, had a history of alcohol, whereas 226 did not. The OGD scopy of Barrett's esophagus was negative in about 360 patients, and it was positive only in 28 patients. And the histopathological finding was also positive in 18 patients, and that was about 4.6%. This is the a table depicting the statistical significance of all these factors. The HPR finding was on the age was not statistically significant, along with the association with the sex, and the BMI was considered was seen as statistically significant. Regurgitation and smoking, regurgitation was found to be significant. Alcohol was not found to be significant. The p-value was high. And this is a OGD scopy finding and the confirmation of the on biopsies. We found that those who had an OGD scopy finding that was positive. That was if there was if intestinal metaplasia was seen, if there is a violet colored epithelium, it was still negative in about 20 out of 28 patients who had OGD scopy finding. About only 18 patients were positive. Coming to the discussion, this was a cross-section study consisting about 388 patients with a mean age of 54 years, and 28 out of 388 patients, that is about 7.2%, had features doubtful of Barrett's esophagus. And this columnar epithelium had a characteristic reddish color and velvet-like texture, and it must line about 1 centimeter or greater of the distal esophagus. Only when this criteria is met, we take a biopsy. And out of these 28 patients who had features doubtful of Barrett's esophagus, only 18 patients, that is about 4.6%, were confirmed to have Barrett's by histopathological examination. And other factors like age, about 39.4% of the study population were above the age of 60 years. But this was considered on statistical analysis. The p-value was high, and increasing age therefore cannot be considered as a risk factor for Barrett's esophagus, according to our study. And about 59.3% for males and 40.7% for females. And this is also not very statistically significant. Therefore, the prevalence of Barrett's cannot be does not change with the sex of the patients. We also found that being overweight or having a high BMI or having obesity can be considered as a risk factor because the p-value was low, and about 35.82% of study population were having a BMI more than 25. So this can be considered as a risk factor. And overall, about 50.3% reported heartburn, and the prevalence of Barrett's in those with heartburn was only 2.83%, and those without was 1.8%, but it was not considered, it was not statistically significant. Therefore, heartburn alone cannot be considered as a risk factor. And about 37.6% patients reported features of regurgitation. The prevalence of Barrett's in those with regurgitation was 3.35%, and those without was 1.28%. It was statistically significant because p-value was low. So we can say that patients who had features of GERD, like regurgitation, was a high risk for developing Barrett's esophagus. And about 22.9% of study population were smokers. The prevalence of Barrett's esophagus in smoker population of the study group was about 1.03%, and in non-smoker was 3.6%. The p-value was high, so we cannot say that the occasional regular smoking cannot be considered as a risk factor for Barrett's esophagus. And coming to the alcoholism part, about 41.8% had a history of alcoholism, but this was also not considered statistically significant because of the high p-value. Whether it is occasional basis or on a regular basis, alcohol cannot be considered as a risk factor, according to our study. Coming to the conclusion, we at our hospital in Amla, we had a prevalence of Barrett's esophagus for those who were undergoing OGD scopy. It was about 4.6%, and the patients who had a BMI more than 25, and those patients who had features of GERD like regurgitation were found to be risk factors for the development of Barrett's esophagus. And other factors like age, sex, heartburn, smoking, and alcoholism were not found to have an association with the development of Barrett's.